This presentation provides some background on a clinical trial called SHARP, which stands for sphincterotomy for acute recurrent pancreatitis. The pancreas is an organ of the digestive system located in the upper part of the abdomen, behind the stomach, and in front of the spine. The pancreas has two main functions. First, it produces digestive juices that are secreted into a tube called the pancreas duct, which connects the pancreas to the small intestine. The juices help to break down food for absorption. Second, it produces insulin and other hormones which are secreted directly into the blood, helping to control sugar levels. Pancreatitis refers to the inflammation of the pancreas, and it is manifested by abdominal pain over a short period of time, typically hours to days. There are many causes of acute pancreatitis, but the most common is gallstones. Gallstones cause acute pancreatitis when they move from the gallbladder and obstruct the pancreas duct, causing activation of the pancreatic juices inside, resulting in inflammation of the pancreas. When the pancreas becomes inflamed and scarred, usually over a longer period of time, this is called chronic pancreatitis. Some patients who suffer from acute pancreatitis may go on to develop scarring and chronic pancreatitis, especially when they have more than one episode of acute pancreatitis. Chronic pancreatitis often causes pain that can vary from being present only off and on to constant pain. In addition, chronic pancreatitis may cause diabetes, diarrhea, and weight loss, and is a risk factor for pancreatic cancer. When most people are born, the opening of the pancreas duct empties into the small intestine alongside the common bile duct. The common bile duct is the drainage tube of the liver and gallbladder. However, about 5 to 10%, or 1 in 10 people, are born with pancreas divisum. Pancreas divisum is a congenital variation in the anatomy of the ducts of the pancreas, in which a single pancreatic duct is not formed, resulting in two distinct duct openings in the small intestine at the major and minor papilla. The minor papilla is typically a smaller opening, which in theory can become a source of obstructed juice flow. Most people with pancreas divisum never have symptoms and live their whole life without even knowing that they were born with this. However, some patients develop acute pancreatitis and their doctors are unable to find a definite cause other than pancreas divisum. In these cases, it is believed that pancreas divisum might cause acute pancreatitis because the opening is too small. The concept is that when pancreatic juices cannot flow into the small intestine easily enough, they are trapped inside of the pancreatic duct, and this triggers acute pancreatitis. In people who have pancreas divisum and repeated episodes of acute pancreatitis without another clear explanation, some undergo treatment of their divisum by enlarging the opening through a procedure called a sphincterotomy. This is when a doctor performs an incision or cut on the opening of the pancreas duct. This incision is usually made during a procedure called endoscopic retrograde cholangiopancreatography, or ERCP. For this procedure, doctors use a combination of X-rays and an endoscope, a long, flexible, lighted tube, to find the opening of the duct where fluid drains out of the pancreas, as is shown here. The endoscope is advanced through the mouth and into the first part of the small intestine, into which the pancreas drains. After the opening of the pancreas is identified with the help of X-ray, a very small catheter or tube is advanced into the pancreas duct. Then the doctor makes a cut in the opening of the duct to allow better drainage of fluid from the pancreas. This maneuver is called a sphincterotomy. The goal of this procedure is to enlarge the minor papilla to reduce your chances of having more acute pancreatitis episodes by improving drainage of fluid out of the pancreas. ERCP and enlarging the opening of the pancreas duct has been done for more than 30 years. Small studies suggest that this procedure can be helpful, but it remains a point of major controversy. The bottom line is that we don't know if it works. The only way to prove it is by collecting information about patients who have recurring episodes of pancreatitis and pancreas divisum, some who undergo the ERCP procedure and others who do not, to see if the procedure reduces future pancreatitis episodes. The disagreement over ERCP is increased since the procedure itself has important health risks, both in the short term and long term. Even though ERCP is performed to help reduce the chance of future pancreatitis, the procedure itself may cause pancreatitis in 10 to 20% of cases, or 1 to 2 out of 10 people. While most of these episodes that occur after ERCP only last a few days, in rare cases the pancreatitis caused by ERCP could be severe. In addition, after the opening is enlarged by sphincterotomy, it is possible that a scar could form at the site of the cut later. In some of these cases, the scarring could lead to a blockage of the pancreas. This blockage might lead to pancreatitis, pain, or both. Recognizing the public health importance of this topic and the controversy that has spanned decades, the National Institute of Diabetes and Digestive and Kidney Diseases, or NIDDK, a component of the U.S. National Institutes of Health, has funded a study to try to answer this question: the sphincterotomy for acute recurrent pancreatitis, or SHARP trial. The study is being conducted at more than 15 centers across the United States, Canada, and Europe. More than 200 patients will be enrolled at these centers. Patients who have suffered 2 or more episodes of acute pancreatitis, have pancreas divisum, and do not have another obvious cause for their pancreatitis will be asked to participate in this trial if they are seen by a gastroenterologist at one of the participating centers. A participating doctor will perform a careful assessment to make sure there are no other obvious causes for the episodes of pancreatitis. If the only finding is that of pancreas divisum, the patient will be approached for participation in the SHARP trial. If the patient consents to participate in the SHARP trial, a doctor and a research coordinator will gather information during an interview which may occur at the time of the initial consultation visit at a participating center. The patient will then be prepared for the ERCP procedure as per normal clinical routine. This typically requires an 8-hour fast and holding blood thinner medications if applicable. The patient will be sedated and undergo an endoscopic ultrasound procedure. This involves the insertion of a lighted tube through the mouth and into the stomach and first part of the small intestine. The ultrasound procedure is useful in clinical practice to assess the pancreas for causes of pancreatitis and for subtle changes of scarring in the pancreas that could have been missed on previous tests. If the ultrasound procedure does not identify a clear cause for pancreatitis, the patient will be randomized, like the flip of a coin, to either have the ERCP procedure or not. If the patient is randomized to ERCP, the patient will have this done while they are still asleep. The ERCP procedure will be performed by a doctor who has a lot of experience in doing them, and it will be completed using the same techniques that are used in usual clinical practice. The only major difference is that the doctor will not tell the patient afterwards whether or not the ERCP procedure is performed. During the ERCP, the doctor will enlarge the opening through the sphincterotomy maneuver, which is the standard technique used in practice. If the patient is randomly assigned to not have an ERCP, the ERCP procedure will not be performed. Again, the patient will not be told afterwards that an ERCP was not performed. The reason the patient is not told whether or not the ERCP was performed is that it is possible that this knowledge could impact some of the results being measured during follow-up. The research study will cover the costs of these initial procedures, and the patient will receive a small stipend for their time and willingness to participate. All patients will be monitored in recovery in the same way that a patient would be after ERCP. Basically, this means careful monitoring for signs of complications and receiving intravenous fluids during this period. It is expected that most patients will be able to leave the hospital on the same day as the procedure. All patients will be asked to follow up at the participating site for a visit 30 days after the procedure to assess for new or ongoing symptoms, complications from the procedure, and pancreatitis episodes. Every 6 months, patients will have a telephone visit with a research coordinator to assess for pancreatitis episodes and gather some information about how the patient is feeling. Patients will be followed for up to 4.5 years. 18 months after being randomized, the patient will return to the participating center for an interview and to undergo an MRI scan of the pancreas. The MRI scan will help to determine if the pancreas has changed during the follow-up period. Of course, if the doctor believes an MRI is indicated before this time, it may not be necessary to repeat it at the 18-month visit. The study will cover the cost of this MRI scan if it is only done for research. In addition, if there is a reason that the MRI cannot be performed, for example because of a cardiac pacemaker, it will not be done. During this in-person visit, the patient will also be asked to give a small amount of blood and stool to test for diabetes and pancreas enzyme activity. The cost of these tests will also be covered by the research study. As part of your standard care, an ERCP may be recommended during follow-up if pancreatitis or pancreatitis-type symptoms occur on 2 separate occasions or if a new indication for ERCP arises. Many patients have pancreatitis, and some of these patients have pancreas divisum, and doctors remain unsure if ERCP is the right procedure to offer them. The results of the SHARP trial could be very helpful in guiding doctors and patients in making a more informed decision. The study is designed to also provide important and new information on why some patients with pancreas divisum get pancreatitis and what the significance of pancreas divisum really is. Centers participating in the SHARP trial and important contact information for each of them are enclosed on this slide. If you have not already visited a participating center, I would encourage you to ask your doctor if this might be useful. Thank you for your attention throughout this introduction.